Good afternoon. Welcome back to UCSF Medicine Grand Rounds. I'm Bob Wachter, chair of the UCSF Department of Medicine. We've taken a few weeks off. I hope you have had some time off as well. Welcome back to our live audience from the Department of Medicine and throughout UCSF, as well as the UCSF Health Network. As usual, we will post this video tonight on YouTube at about 7:30, and I will tweet out a summary of the session as well as the web address. Our previous grand rounds are now closing in on 1 million views. A few quick ground rules for our live audience are shown here. Put your Zoom window in full screen mode. If you have questions, type them into the Q&A box, and my colleague Quinny Cheng is monitoring them and will pitch some of them to me, and we'll get to as many as we can during the two Q&A sessions that we have. The pace of new developments in COVID and the economy, in racial justice, the presidential campaign, continue to be head-spinning. And now in the Western states, we can add yet another crisis, an extraordinary fire season, and the climate change that underlies it. It's worth taking a moment to acknowledge this unbelievable situation that we find ourselves in, and the time and the energy and the angst that go with it. I hope you're taking the time to care for yourself and your loved ones and to be thankful for the good things and recognize that at least some of this will pass. Today, we're going to cover a wide swath of issues as they relate to COVID. Our first presentation will be our old friend George Rutherford, who is the Salvatore Pablo Lucia Professor of Epidemiology, Preventive Medicine, Pediatrics, and History, with appointments both at UCSF and UC Berkeley. George will update us on the state of the pandemic, including what's happening in California, the sort of mini surges that we're beginning to see in the Midwest, the Sturgis motorcycle rally, the the situation in colleges, and whatever else George feels like it's worth talking about. So we look forward to that. After George, we will have a return appearance from Monica Gandhi. Monica is Professor of Medicine and Associate Division Chief of the Division of HIV, Infectious Disease, and Global Medicine, based at Zuckerberg San Francisco General Hospital. She's also Director of the UCSF-Gladstone Center for AIDS Research. As you recall, Monica spoke here a couple of months ago about a theory supported by reasonably strong circumstantial evidence. And I should say I still get emails about the cute hamsters wearing masks, that masking might lead to a more benign course of COVID. She and George have a fantastic article in today's New England Journal of Medicine in which they explore this idea in more depth. Today, Monica will speak more generally about what we know about the fatality rate of COVID and whether it's changing, and if it is, what is the explanation? And I'm sure she'll get into this mass theory as well as part of that. After George and Monica speak, we'll do a Q&A with the two of them. That should take us to a little before 1 o'clock. Starting then, we'll hear a final presentation about a really intriguing therapeutic innovation developed here at UCSF. The speaker will be Aashish Manglik, who's assistant professor in the Department of Pharmaceutical Chemistry, as well as anesthesia and perioperative care. Aashish, whose own research focuses on the role of drugs and their receptors, will discuss AeroNabs, an inhaled synthetic molecule that he and his colleagues designed to coat the receptors in our upper respiratory tract so that the coronavirus is unable to gain purchase. It's a fascinating idea, and Aashish will describe the science and potential clinical applications of this novel approach. That should take us to about 1:15 or 1:20. We'll inevitably get into some vaccine news today. It's hard not to, but a teaser for next week's Grand Rounds, co-sponsored with the Institute for Global Health Sciences. Next week's Grand Round was focused exclusively on vaccines with several speakers, including Peter Hotez, who's Dean of the Baylor School of Tropical Medicine and has been all across the media for the last week or two, as well as Heidi Larson, who directs the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. So that should be fascinating as well. But let's get into today, and let us start with George Rutherford. George, you are on.
Thanks, Bob. It's good to see everybody virtually. So the United States is at we're in the midst of the decline in the second wave of infection. As you can see on this graph on the panel to the right, there have been almost 6.4 million cases reported in the US. We're averaging somewhere over 35,000 cases a day still. The cases have been persistently elevated across much of the country, but particularly but at lower levels than in July. But they're increasing in the upper Midwest, as Bob says, in these micro outbreaks. and in the Mid-South. The largest per capita number of cases in the past 7 days have been in North Dakota, South Dakota, Iowa, Montana, Arkansas, Oklahoma, Arkansas, Tennessee, Kansas, and Alabama, and also in Guam, where we've been helping the Guamanian government with contact tracing training by Mike Reed and Laura Bubeck. The deaths, there have been 190,714 deaths reported in the US, as Monica may get into a little bit. This is probably an underestimate by about 10%, maybe even a little bit more. And we're averaging something like 725 deaths per day here in the US. May I have the next one, please? Cases are scattered, as you can see, compared to earlier weeks when you would see this map. There was a lot of cases in the South. The South was pretty red. Now they've sort of moved more into the Middle West and even into the upper Midwest. There's quite a bit of activity around Memphis in Western Tennessee, as you can see. Here in the West, this remains a disease that's predominantly among Latinos and predominantly now, not only in urban areas, but in rural areas as well. The next one, please. Why is there so much disease in rural areas, you ask? Here's the answer. And when you talk about super spreader events, this is the classic of all time. The 80th annual Sturgis Motorcycle Rally in Sturgis, South Dakota, from October 7th to 16th. Earlier this year, this 10-day event drew 460,000 participants. I've gone through all the photos of it, trying to pick out something that's both showable and representative. This was pretty close. We've got some great ideas for Halloween costumes, just to warn my wife in advance. However, there were a number of cases of transmission there and then a ton of secondary transmission cases. And it's estimated that there were an additional, this is all estimates obviously, 266,796 cases occurred because of transmission in Sturgis during this motorcycle rally, which accounts for almost 20% of all cases reported in the US in August, and a total cost of care of $12.2 billion, which is to say if you paid everybody $26,000 to stay away, you would have come out ahead. The next one, please. So I thought I should say a couple of words about super spreaders and super spreading events. Super spreading events are, they're probably relatively common, but aren't recognized. CDC defines a super spreading event as having 10 or more cases, but other people look at it differently. This is a review of 9 cases that is from, I can't quite see it, but I think it was from, it looks like the Lancet. There are, the overall secondary attack rate was 35%, with a range of up to 100%. Okay? And this suggests transmission is driven by a relatively small number of high-risk, close contacts. Now, how do we put that together with what we know about the transmission dynamics? The next one, please. So what we're thinking now is that, as Monica's article, or I guess I should say Monica's and my article says, but it's really Monica's, there is an ID50, an infectious dose of virus. The more you get, the more likely you are to get infected. So the people who have higher doses of virus, higher viral loads in their anterior nares and their nasopharynges and their oropharynges are more likely to transmit than people who have lower loads. And so when do you have the highest load? Well, you probably have the highest load right around, so if you said infection starts on day 0, symptom onset on day 5, you probably have, the PCRs will turn positive on day 3. On day 4, you're probably a big time transmitter. So days 4, 5, 6, maybe 7, maybe 8. But it's a relatively narrow window of about 3 or maybe 4 or 5 days where people are at their most infectious and most likely to spread. And the upshot of this is, if you could go to the next slide, please, that and this is a wonderful article, a modeling paper from Seattle that talks about wrong person, wrong place, wrong time, that these super spreading events are essentially accidents. They'd have nothing to do, very little to do with immunity. They have very little to do with anatomy. They probably don't have a lot to do with purposeful behavior. It's just that people who are at this most infectious stage come into contact with people who are susceptible. Okay? So if you look at this model here, with the pink on the left-hand panel, with the pink area under the curve, the maximum transmission is going to occur at the height of that viral load curve. And so the people that you come in contact with are all going to get infected. If you move down the curve, it's going to be a much chancier event. And the number of people you come in with, the proportion of people you come into contact with who become infected is going to be less. So that gives you some feel for this. And by modeling these things out, this is where the days 3, 4, and 5, or 4, 5, and 6 of infection come from. I'm personally a fan of 4, 5, and 6. So that's the kind of the news about super spreading. It's not that people have prolonged carriage. It's not that they have something anatomically wrong with them, so they have more virus in their anterior nares. It's nothing like that. It's just a matter of luck and timing. The next one, please. So moving away from super spreading back to California. In California, there have been 747,800 cases of COVID-19 reported. We're averaging about 3,880 cases a day. And it's, as you can see, we're similarly on a downslope. This little dip here in the middle, if you look at the left-hand panel, the middle of the second wave curve is all artifact, and that had to do with a data meltdown at the California Department of Public Health. We're also starting to see declining deaths, and but we're still averaging almost 100 deaths per day statewide. There have been 13,990 deaths. And pay attention to what Monica's going to tell you about Spain. I left that one for her. The next one, please. If we look at what counties have the most cases, on the right are the last, these are absolute numbers of cases. So the big Southern California counties have lots of cases, but so does Santa Clara, Sacramento, and Fresno. But if you look at per capita, these are all agricultural counties. Kings, which is, if I had the cursor, I'd show you, it's the one above Kern to the left. So Kings, San Benito, which is next to Monterey County, to the right of Monterey County, sorry, to the east of Monterey County. It's where Hollister and San Juan Bautista are. But that's a kind of bedroom for the people who work in agriculture in the Salinas Valley. Stanislaus, Madera, in the San Joaquin Valley, Imperial, with big agricultural area in the southeast. Butte County in the Sacramento Valley, which is where there have been horrendous fires here recently. So who knows what's going to happen, how that's going to mix together. Monterey, where the Salinas Valley is, and then Fresno, Tulare, Fresno, and Modesto. So again, we've seen this sort of gradual migration, at least in terms of per capita numbers of cases, into the agricultural parts of the state. The next one, please. This just shows you in the Central Valley that we're really seeing kind of almost a first wave of infection. They pretty much dodged it early on, but now you can see how it's spread out, and it's pretty evenly divided amongst the counties, with Fresno, which is the biggest county in the valley, recently having the most cases. But you can see there's a clear downturn here, which is good. The next one, please. Here in the Bay Area, we've had 92,000 cases reported. We had 528 new cases yesterday. There have been 1,234 deaths recorded, and 3 recorded yesterday. As you can still see, we're sort of on the upswing in deaths, but are clearly on the downswing in terms of cases. And again, this little sort of saddle in the middle of the two peaks is an artifact. There's a whole new case counting system out by the state that depends on who's on the good, naughty, and nice list. And this gives you what the state is saying this is the rubric they're looking at, the number of cases per 100,000 population per day, a 7-day average taken 7 days before. So it's the average of days 13 through 7 before the current date. And they only change this on Tuesdays. So of the Bay Area counties, there are 4 that are in the not as bad range, which are Santa Clara, San Francisco, Marin, and Napa. And the reason those are, there's an adjustment here that's actually on the state website. It's clearly laid out. So the more you test, you get some credit for that to a point of where you're testing at twice the state average in terms of numbers per capita per day. You can have your actual case rate multiplied by 0.6, so you get a 40% discount. And that's why San Francisco's on the red list, and that's why Santa Clara's on the red list. Consistently, though, and this is really important, I've been putting these data together for a long time, and this is really the first week that I've seen all the effective reproductive numbers, the R sub E's, well below 1. And even a particularly impacted county like Sonoma, again, an agricultural county largely, has an R naught of less than 1. So that's all good. The next one, please. And this is just a slide that shows you how we're kind of faring kind of in our early sheltered in place first wave and now into the second wave with clear declines. And Alameda's become sort of the big hotspot now. And there's a lot of interest in trying to understand exactly what's going on in Alameda. There'll be I think it's this weekend coming up, there's going to be a big testing event in the Fruitvale area of Oakland being conducted by Professors Alicia Fernandez and Kim Rhodes from the Department of Epidemiology. So we look forward to seeing what those data look like. The next one, please. And this shows you San Francisco itself with clear first wave, and then this clear second wave and declining transmission. And there have been 87 deaths to date in San Francisco. The next one, please. And I think that number of deaths is really quite remarkable. This is data that Dr. Jim Marks put together from the Department of Anesthesia and the Emergency Operations Center for the city. And it's remarkable. Just look at the deaths per case. And you can see how different San Francisco is than other places. Right? We have 1/12 the number of deaths per case as New York, right? We have fewer than 10 deaths per 100,000 inhabitants, which is quite a bit different than these other places. And we also have relatively low case counts, but not the lowest case counts. But still, I think that we've had an amazingly good response here in terms of mortality and prevention of mortality. Next one, please. Now, about 3.5 weeks ago, the state scrapped its old system of the watch list and being on or off the watch list, and as in its place introduced, I think, a quite well thought through 4-tier system. And there's a lot of nuance to this, and there's a fair amount of detail to know. But basically, at the bottom or top of the list, the worst part is widespread infection, which is purple, then substantial, which is red, which is San Francisco now, by the way, in case you can't see clearly. Moderate is orange, and minimal is yellow, and they don't have anybody with none, right? So that they very clearly stayed away from green. But you can see in the Bay Area, Napa, San Francisco, Santa Clara, and Santa Cruz are all at the substantial transmission, but not widespread transmission levels. Alameda, Contra Costa, San Mateo, Marin, Sonoma, Solano are all at the high levels. And in most of the valley, Madera, Fresno, Kings, Tulare, we put into our catchment area, Stanislaus and San Joaquin that go to the catchment area in Fresno are all in the widespread transmission category as well. The next, please. And for those of you who want to peruse this, these are the actual rules. Basically, just to kind of boil this down, basically you're on the list. Once you get into a tier, you stay at that tier for 3 weeks. You can't change tiers up or down. If in the last 2 weeks you have performed at a level of the next best tier, at the end of that 2 weeks you can move up a tier. That's if I'm sort of hamstrung by my Judeo-Christian heritage with the bad at the bottom and good at the top, but the state sometimes does it one way and sometimes does it the other. But the idea is that you can change for the better only every 3 weeks, and that's if you've done better for the last 2 weeks. Schools that are in the red, by the way, counties that are in the red can have their schools open. If they're in purple, they can apply for waivers, but the waivers only apply to elementary education. And there are a whole variety of what can open and what can't open that show up on the state websites, but counties can impose additional restrictions on top of that, which is what's happened in Alameda and San Francisco. So you really need to look at the county websites to understand exactly whether you can get your hair cut this weekend or not. The next one, please. Now, all this is temporizing for waiting for vaccines. So the vaccines are cooking, and they seem to be cooking pretty successfully, except for a little problem 2 days ago, which I'll discuss. There are 3 vaccines that are in phase 3 trials in the United States. One by Pfizer and BioNTech, which is a messenger RNA vaccine. One by Moderna and NIAID, which again is a messenger RNA vaccine, both of which target the full-length spike protein. And the thing to notice about these are 2 things. First is that they require 2 doses. So when you hear there's 100 million doses, that means there are enough doses for 50 million people. So you have to take every number and divide by 2. And the other thing is these mRNA vaccines have an extreme cold chain requirement and need to be kept at minus 70 degrees centigrade until 48 hours before use. They're good for about 48 hours being kept in a regular freezer, but but this cold chain is going to be a problem. The third vaccine is an adenovirus vaccine. So with the mRNA vaccines, you'll hear about this in detail next week, but basically you're injecting mRNA, which gets picked up and put into cells and kicks out like the full-length spike protein that antibodies are made to. With the AstraZeneca and Oxford vaccine, you're given a live adenovirus that has this protein already, this piece of RNA already incorporated in it. And so it expresses the spike protein that way. This has much less complicated storage and it can be refrigerated. And the adenovirus that's being used is a chimpanzee adenovirus. The Russian vaccine that you've heard about uses a human adenovirus for which a lot of people have some immunity because you get immune when you get colds. The chimpanzee one, presumably, if you're not working at the circus or something, very few humans are going to be exposed and have pre-existing immunity. So that's the beauty of the chimpanzee vaccine. The next one, please. So on the Friday before Labor Day weekend, CDC astounded everyone by sending around to all the state health departments 2 scenarios about assume you have a vaccine ready in late October, what are you going to do? And it's pretty clearly, one was the Pfizer vaccine and the other was going to be the AstraZeneca vaccine. So they sent around 2 scenarios, and this is just one of them. So it's assumed that there are 2 million doses available by October 2020. By the end of December, there might be 20 to 30 million doses available. Remember, divide the doses by 2 to get to the number of people. And again, this is minus 70 degrees. So it's the complications, it's complicated storage and all that stuff. And then they talk about priority populations. And may I go to the next one, please? And I've pulled these out and I showed them. So the priority vaccinations, priority populations for vaccinations, this is for planning purposes only, are healthcare professionals, including long-term care facility staff. The idea here is there's probably not enough for all the health professionals, but those will be the really forward-facing people like in the ICUs and emergency departments, those kinds of settings, and intensive care and the wards. The second group are essential workers, to be decided, okay? To me, the essential workers are the guys picking fruits and vegetables in the Central Valley and the Salinas Valley, the Coachella Valley and the Imperial Valley. You know, that's a real essential worker. If we don't have that, we're not going to have food. Other people will think it's the prison guards or. You know, you can just fill in the blanks along the spectrum. The national security populations, not unreasonable. The Navy has had a horrendous problem with COVID on their large warships, and then long-term care facility residents as forth. So that's the planning document. The next one, please. So the question is, will we have a vaccine in October and November? So the last two slides, the two data and safety monitoring boards for the large trials will meet in October. They'll look at the incidence of disease and adverse events in the two trial arms, meaning vaccine and placebo, with a priori stopping rules. And the trials are actually sized to find an efficacy of 50%. 50% is the biggest sample size you can get, right? So anything less than that, like a 90% or more than that, like a 90% efficacy, will also be found. If a data and safety monitoring board stops the trial because of a benefit, the manufacturer can apply for an emergency use authorization from FDA. They've been used tons of times for laboratory systems, as we've seen a lot during COVID, but they've only been used once before for therapeutics, and that was for anthrax vaccine for inhalational anthrax in 2005. So to say this is uncharted waters is an understatement, and they'd have to show clear clinical efficacy and minimal harm. This caused a lot of this. The FDA commissioner started talking about EUAs a couple of weeks ago for vaccines, made everybody very, very, very nervous given the timing of the election. And 9 CEOs of the big vaccine companies issued a safety pledge and put out a joint statement saying that they were not going to go forward unless they were absolutely certain of safety. The next one, please. Now, so as just kind of 2 days ago example of this, the AstraZeneca vaccine was put on hold. The trial was put on hold. And it was, and there are 2 trials going on. One's in the UK, Brazil, and South Africa, and the other's in the US, which is just starting to enroll. They halted all new enrollment on September 8th because of a severe adverse event in a woman who was a vaccine, who was a participant in the trial, and she was hospitalized with transverse myelitis, basically an autoimmune disease of the spine. She was in the vaccine arm, just so everybody's clear on that. She's improving and was discharged yesterday. The clinical trial actually had been previously halted for another neurologic disease, which turned out to be a new onset case of multiple sclerosis that was judged not to be vaccine related. AstraZeneca has commissioned an independent review board to determine when to lift the hold. Now they can have the last one, please. And I'd just like to thank the people who've been helping me over the whole summer and spring, put all these slides together. Hillary Spindler from our group at the Institute for Global Health Sciences, Shah Radari, a 4th-year medical student, 2 of the preventive medicine residents, 3 of the preventive medicine residents, Mia Kansawa, James Hu, and Cameron Staken, Lena Bertozzi from an undergraduate at Cal, and most recently Sarah Coven, who's on a gap year from Princeton, who's helping with the slides now. Thank you all very much, and I look forward to answering questions.
Great, George, thank you. Let me I have one question for you now. I think we're getting Monica's slides up. So the super spreader events, it sounds like our best thinking now is just random chance that somebody has a super high viral load at the time. But what does it say about the question of droplet versus aerosol? I mean, it's sort of, if you're getting 50 people or at a party or something, I assume you're not within 6 feet of 50 people, or maybe you are. Does it say something? Does it help us understand more about the mode of transmission?
Not really. I mean, these are presumably all droplet spreads. There have been a couple of new case reports of pretty clearly demonstrated aerosol transmission, one in a nursing home in the Netherlands, and I don't remember where the other one was, I'm sorry. And so, but it seems to be a pretty rare event. ASHRAE, the American Society of Heating, Refrigeration, and Air Conditioning Engineers, has come out with new standards for air conditioner efficiencies and filters. Filters, if you're going to recirculate air, basically the standards are for large events, you should do 100% exhaust cycles. Basically, you exhaust all the air to the outside, you don't try and recycle it, which is hugely inefficient from an energy standpoint. But we'll see. I mean, but you know, when you see those pictures of Sturgis, first of all, everything's outdoors, right? And so and everybody's right on top of each other. And so that's clearly a setup for droplet transmission. And you can say it's safer to be outdoors than indoors, but if I'm a foot away from you coughing in your face, that's not, all the UV light in the world is not going to prevent that from happening.
Got it.
So it's all about crowd behavior on top of everything else. And I don't think the super spreaders necessarily have an extraordinarily high level virus. It's just that they're in that peak period where people have lots of virus.
Got it. Great. Okay, we'll bring you back again in about 15 minutes for the Q&A with Monica. With that, let's bring Monica on.
Okay, thank you. So I'm going to talk today about factors decreasing mortality of COVID-19. And before I talk about that, I have to convince you that there's the possibility that mortality of COVID-19 has been decreasing over time. Next slide. So are fatality rates of COVID-19 decreasing over time? Well, remember the two definitions of fatality. Really, it is the definition of death over different denominators. Case fatality rate means fatalities over the number of cases. That totally depends on testing. The more you test, the lower you'll have a very large denominator and your case fatality rate may seem lower. And then the infection fatality rate is the number of deaths over the number of infections. And it's actually impossible to know the number of infections. There's a Nature Communications article from today that we've probably had 20 million in the US alone. So I'm going to try to convince you by separating from specific denominators. Let's just assume for the sake of this talk that we've essentially in the US had a wave in March, April, and another wave in July, August. So next slide, let's look at the US data. So this is data from the CDC, and this isn't depending on number of cases or number of infections. This is not divided. This is essentially the percentage of deaths due to a pneumonia or an influenza or COVID-19, essentially number of deaths due to respiratory illnesses. And that you can see that in 2018, 2019, we had seasonal variation, but we certainly didn't have what we saw in 2020, which is most absolutely certainly because of COVID-19. And in the first wave, which we'll call April and May, we had that huge spikes in deaths in the US. And then you can see, and I call this the continuation of the first wave in July and August, because we had that lull where things were getting better. Then we reopened and we had the continuation of the first wave. And you can see that the death rate from all these respiratory illnesses, presumably mostly because of COVID-19, is lower. So it does look like the mortality rate in this country has decreased from that first to that second wave. Next slide, please. Is there data from other countries? This is data that was updated yesterday from the Center of Evidence-Based Medicine at the University of Oxford from Germany. And you can see that the cases and the deaths mirrored each other at that, again, that kind of first wave, the March, April, and the curves were the same. And then there was a lull and cases went down. And then as cases have been going up in Germany and Europe, just as they had here in July and August, but mostly August, you can see the death rate has not followed suit. Could it be a lag? Possibly, though I have to say it's been like 9 weeks since the cases have gone up and even counting higher in other places of Europe. And it really does look like the deaths are deviating from the cases. The deaths are lower than what we expected to see from the beginning of the pandemic. Next slide is data from Spain. And you can see here that, again, the cases are on the upper bar in blue and the deaths are in the lower bar in red. And you could see that the cases started rising and then there was that typical lag and then the deaths also increased. But here, over the last 9 weeks, we have seen upticks in cases in Spain with reopening, but the deaths have not followed suit, even with the typical lag. And so it's been 9 weeks later, deaths are not following suit. And in fact, there's been only a minor increase in daily deaths in August. So let's watch it, but it's extremely hopeful data, I think, from now Spain, Germany, US, and then next, go to the last slide. Next slide, please, for the UK. So here in the UK, similar data from the Center of Evidence-Based Medicine that you can see that the blue here is cases and they're lagged actually, and then the deaths here are in orange. And as the cases have been going up, like so many cases in Europe have been going up over the month of August, the deaths have not followed suit. And they did actually imply a case fatality ratio, and it does seem like it's been going down. So we'll come back to this, but let's go to the next slide and ask the question, okay, what are the possible reasons? If I convinced you that the mortality rate from COVID-19 has been going down from over July and August than it was at the beginning, what are the 4 possible reasons? And let's talk about younger age as one reason for diagnoses. Let's talk about population-wide masking. Let's bring up immunity, and then we will end with better treatments and preparedness. And I do think that these are the 4 main reasons why we're seeing decreased mortality with COVID-19. Next slide, please. So in terms of younger age, is the mortality rate decreasing because of younger ages infected? It's certainly no mystery to this audience that really age is a significant risk factor for increased death from COVID-19. And this is data or a nice figure from the CDC that looks like, as you go up in age, you see these 4 times, 30 times, 90 times, much higher rates of death with COVID-19. So is it because when we open up, or younger people, they're tired of it and they're getting infected? Is this why we're seeing the decreased mortality, because they're not as likely to die? Next slide. Well, it is true that younger people are getting infected worldwide. And on August 18th, the Post covered the WHO said that in regions all around the world, this was specifically, they were talking about the West Pacific, young people are emerging as the group that's more likely to be out and getting infected. Next slide. However, has this been looked at systematically? Not everywhere, but this is good data from the University of Oxford, again, the Center of Evidence-Based Medicine. And I had shown you a couple of slides ago the decreasing mortality rate of COVID-19 in Germany. And you can see that here, just looking at the case fatality rate, it actually fell in all age groups. This was just data from yesterday. So it fell among the younger ages, which is the red, 35 to 59, but it fell among even the older 80-year-olds. So this argues against age being the main factor, younger ages at diagnosis, of why our mortality rates are decreasing with COVID-19. Next slide. So let's turn to population-wide masking, which I have talked about before in this medical grand round, so I'll summarize that data a little bit quickly and then get into some more. Next slide, please. So as we talked about before, really masking, the idea here and why this would decrease severity of disease or mortality from COVID-19 is that just in general, masking reduces the viral inoculum to which the wearer is exposed. It's very simple, actually. And do keep in mind that the word is inoculum or dose and not load, because the load is what we produce as individuals. So, an N95 will filter out the majority of viral particles. And we've had discussions here before about the need for those, but I don't think that anyone but healthcare workers need that. We're asking for population-wide masking. This is totally changing behavior for the US. And so it's really just those kind of cloth masks or the surgical masks. They're 2-ply for the cloth, and they filter out the majority of viral particles. And I do think there's ample evidence. And again, you can't prove this theory because you can't randomize control trial, randomizing half of the people to mask and half not. There's just too much evidence for masking at this point. But just like evolution, if you just keep on getting lots and lots of evidence, observational evidence, the theory gets stronger. And I think there is ample evidence from virologic, epidemiologic, and ecologic studies that reducing the viral inoculum reduces severity of disease. Next slide. I will just divide those into 3 major kind of buckets of evidence. One is virologic evidence. Just quickly, we've known for almost 100 years that the more virus you get in, the more sick you get as an animal. There's been many, many animal studies. The first one was in 1938. It's actually called the Reed and Munch theory after the authors. And then in humans, there's even been an experiment where people were given influenza A. And the more dose you got, the more sick you'd get. Less dose, you wouldn't get very sick. This has been shown in animals with SARS-CoV-2, the virus that causes COVID-19. We really can't do this in humans, but this was a PNAS paper on the top, and you can see that this graph shows that the higher dose you gave the animals, those are the red lines, the more severe their CT scans were. They got more sick. And then on the bottom right, this is my favorite picture in the whole world, but this is this tiny little hamster, and he's getting masked. And he's so cute. And this is a study that showed that if you masked hamsters, not in this way, but sort of more simulated, not only were they less likely to get the infection, but they were less likely to get sick. And this was recent data from Hong Kong. Next slide. What about our epidemiologic evidence? And we've talked about this before here, but there's been some more data out on this, that essentially if the CDC estimates, basically they made this estimation on July 10th, that the proportion of asymptomatic infection with COVID-19 is 40%, which is really weird, by the way. And that's the fascinating thing about this illness, right? It has such protean manifestations from feeling completely well to dying. I mean, it's such a wide range. And how do we increase that proportion of asymptomatic infection? That would be a good thing for society. And so 40% is kind of your baseline rate of asymptomatic infection with COVID-19. It looks like in settings that masked, like a cruise ship setting where everyone masked, the rate of asymptomatic infection was 81%. Food processing plants, people got sick at the beginning of this pandemic, but the president actually mandated food processing plants stay open. And so they started giving out masks. And they mandated mask wearing, and the rate of asymptomatic infection and outbreaks went up to 95%. This is true in jail settings where people are kept away from each other. By definition, they're in different settings. The rate of asymptomatic infection is 95% in mass testings. And then this was a study on the right from MMWR last week from the CDC that looked like healthcare workers who we have been universally masking in our hospital settings since mid to end of March, mostly around March 25th is when it all went into play, in multiple academic medical centers around the US. On a seroprevalence study, it looks like healthcare workers have had a lot of asymptomatic infection. There's a lot of seroprevalence, but they've been masking and they haven't felt those infections. And that's just recent data. And then next slide, I will just bring us back to the slide that George just showed in his talk, and Jim Marks had kindly gathered from the Johns Hopkins website, that this is just sort of interesting. This is showing the same mortality data that George just showed, but I ranked them. in a different way. And you can see that all these cities, we have a profoundly low death per case rate, and we have a very high rate of testing in the United States. It's really low compared to all these other places. And if you look at when mask mandates went into play, it's in a way not fair for the cities on the bottom, New York, Seattle, Philadelphia, Boston, because we didn't know about masking when they were getting their high death rates. And so I would say that the highest death rates occurred in these cities, including New York, of course, before we knew about masking. And then, of course, mask mandates were put into play later. Los Angeles has a little more uneven rate of masking than we do, and they have a higher death rate. Miami actually had a lot of cases. They didn't have as much of a high of a death rate as you would have thought from the headlines. And Atlanta has been struggling with itself. Governor saying no masking, mayor saying masking. So that's an interesting example. Next slide. So let's talk about the third and final reason that I'm going to expound upon for possible reasons for the decreased mortality rate, because I'm not going to expound on better treatments. I think that's pretty obvious, and we'll just touch on that. But let's talk about immunity. Next slide. So it is okay, by the way, for all of you to use the phrase herd immunity. It is not an evil phrase. It is, in fact, absolutely a known way that infection stops being spread. And by definition, what's the definition of herd immunity? It's that if fewer people are susceptible in the population from natural infection or from vaccination, then a virus is bopping around and it can't spread as readily because there aren't people who are as susceptible. And it is okay to say herd immunity. I want to give the audience permission for this. Humans have been, this is a way to combat infection from the beginning. And whether it's wittingly, like Sweden, and we talked about this in Medical Grand Rounds a few weeks ago, or unwittingly, like New York or Italy, I think there is herd immunity likely occurring in many places that is decreasing the level of spread and mortality from this illness. And let me explain what I mean by that. Next slide. So let's think about those unwitting and witting places. Let's think about Sweden, which ostensibly had a stated strategy for herd immunity, and that's debated as well. But there was a high death rate. It'll be pointed out that it's higher than some neighboring countries at the beginning, not higher than others. Absolutely didn't protect the elderly, and there was death rates that were high. But the death rates have been very low over this increases in cases over August and the beginning of September in Europe. New York City, I would call this unwittingly. No one wanted what happened in New York City to happen. It was terrible. It was terrible, terrible. But it really was before we knew about masking. And it was very hard hit. And there was a article in the New York Times on August 20th that showed that there is quite a bit of immunity, at least as measured by antibody testing, which we'll get into that. But in the boroughs, which got hardest hit, there are up to 50% of people have had exposure to COVID. And as you know, the death rate, luckily and thankfully, has been very low in New York City over the last really 2-3 months. It's great. And then Italy, also another unwitting phenomenon of a lot of deaths at the beginning. But you can see that if cases have gone up in Europe, the death rate has not followed suit, like we talked about with some other countries in Europe earlier in the talk. Next slide. So let's just have 1 minute to talk about immunity, because it's really important to remember, and it's just going back to 101, that there's two arms of the immune system. There's B cells that make antibodies, really simple, and antibodies are not the main way that we fight off long-term viral infections. And so the antibodies can go up and go down, to be very simple. And then T cells, which are cell-mediated immunity, T cells, CD4, CD8s, but these fight infection more in the long term. And both T cells and B cells have memory populations that come out and fight a new infection if you're re-exposed. And that's the simplest way to explain kind of B and T cell immunity. And the best part about this virus is that we've had some really hopeful data lately. Next slide. And what I mean by hopeful data is that there's been really hopeful data that just come out actually over the last 4 weeks. Some generated from the University of Washington, one from a group in Sweden, one from a group right here at UCSF, Nadia Roan was a senior author, and one in the New England Journal recently. There's just been a lot of recent studies over the last month that show that really strong T cell and then even B cell immunity and memory T cell immunity is generated even with mild or asymptomatic infection. So how long is that going to last? We don't know. This was, COVID-19 has been out for as long as it's been out, but these were very hopeful studies about how strong the cell-mediated immunity is. And we're waiting for data from from Dr. Henrik from UCSF that shows the same thing. The most profound way to think about immunity is that don't worry about these couple of reinfections that have occurred. We're at 28 million cases and counting, probably many, many more because testing will underestimate the number of cases. And even after all of these cases circulating in the environment, we've had very few reinfections reported. One from Hong Kong, one from Nevada, a couple from Europe. So by definition, greater population level immunity will slow down viral spread. And then I'll end with this next slide, which is the article that Dr. Wachter was referring to that George and I wrote and was published, I think, today, actually. And this idea is that, okay, transitive property of equality, if asymptomatic infection is increased by population level facial masking, and if good immunity develops with asymptomatic infection, then masking may be a way to be kind of a poor man's vaccine while we're waiting for that actual vaccine. And we called it variolation on the way to vaccination, somewhat deliberately and provocatively, because variolation was the process by which scabs from smallpox patients were given to healthy people to give them low-dose virus and give them immunity. And what I mean by facetious is we are certainly not implying that everyone should go out and have pox parties. We're not implying that. We are not saying that people should deliberately get infected. But boy, if you're going to drive up herd immunity, I'd rather do that with asymptomatic infection and low severity of illness than any other way. Last slide. I would just end with, this is not the talk to talk about this, but of course, better treatments and preparedness possibly likely have decreased our death rates from this virus, steroids from Desivir, many, many other treatments coming out, very exciting time for this virus. And I will end there. Thank you very much.
Great, thank you, Monica. That's really interesting. I think we're going to bring George back. So if we could get George on as well. While he's coming, let me ask you a couple of questions about your theory. You didn't bring up another issue that always comes up, which is the virus changing in its nature. Any evidence of that the virus is becoming a more benign thing?
I do not believe that with coronaviruses. There is a lot of antigenic variability in influenza, which is why we have to keep on changing the vaccine every year. There's some antigenic variability with this. I literally, if you're going to go far-fetched, I don't think it's because the virus is mutating and becoming more benign in such a short period of time.
Okay. And the variolation idea, is it that I'm wearing a mask and I actually get a case, but it's a milder case and more likely an asymptomatic case, or that I'm getting sort of more chronic doses of virus over time? Is it sort of a small dose over time, or is it I did get a case, but it was just a milder single case?
That is the weird, your question is excellent. It could be either, but that's the weird thing about this virus, right? That you can get tiny doses. You yourself can produce quite a bit of viral load and you will be called a case. You've never had a symptom in the world, but you'll be called a case. There's quite a bit of controversy, of course, about the testing around this and having low viral loads. But the point is that you are infected because you got even a little bit, you got infected, but you were so able to control it with your own immune response that you don't spread a lot of virus, and you had no symptoms, but you're still immune. So it's either, by definition, you become infected if you swab your nose and your PCR reaction is positive. That's what we call a case.
Mm-hmm. Okay. Actually, maybe both of you weigh in on this. I'm continuously flabbergasted by the 87 deaths in San Francisco. It's an extraordinary number. Monica, you gave one theory, which was that we mask more and we did it earlier. Are there other theories that are, we're all here at San Francisco and at UCSF. I'm sure there's a chest thumping theory that we're better. Is there any evidence of that? Is there some dynamic here where because we got we did not get overwhelmed in any way. The issue of sort of hospital and healthcare system capacity made us better. Certainly, when we had speakers coming on who'd been in New York, it was very clear that they were just overwhelmed, and you have to think some of the outcome relates to that. It just seems like such an extraordinarily low number. That the treatments probably are pretty much the same all over the country as the evidence came out. So it sounds like you believe that the masking is a significant part of it. Maybe expound on that a little bit, and then George, I'd love you to weigh in on what explains that number. It is so unbelievably low.
I would say it is the masking. We're a masking compliant culture, and the city has been really pushing on it, and that's wonderful. That's great. We've done a good job with that. I think also that this is spread has been mainly in essential Latino workers, which is a population we need to protect, but there is younger ages there, and there could be getting immunity just in that population, just like there's immunity in Queens, for example, or the Bronx.
Not explained by demographics in terms of fewer populations at risk, fewer obese people, fewer smokers, any of that possibly going on? And maybe if you want to weigh in, then I ask George.
I mean, people will say that the people who are able to stay indoors and stay sheltered in place, they have done that in San Francisco. Tech people stayed home. Everyone got to stay home. We have a affluent city, and many people stayed home. And I think it's that tragic sort of disparity in what we've seen with the Latinx population here, and white populations, that we have to look at in our city.
Great. George, what do you think?
I mean, there's clear evidence from China that the more overloaded a province is with cases, and cities are with cases, the higher the mortality rate is. So it disproportionately goes up as the density of cases goes up, as the incidence of cases goes up. So that would bespeak your theory of the overcrowding of the EDs and stuff. I mean, there was a lot of planning that went on in San Francisco, and there's a lot of capacity created. And, we may have had the luxury of time, relative to New York, but it was, it worked. And all you have to do is look at Los Angeles. We had the same number of cases on the same day. And, forget that the population's 10 times bigger. It's still, just look at the numerators. We had the same number of cases on the same day. And, they ended up with 1,000, and we ended up with a relatively smaller number of cases. And as a consequence, a relatively smaller number of deaths.
Mm-hmm. Okay. George, what the analogy between May and September feels real in a way that we all felt like the cases are going down, we're going to be okay. Then we saw what happened in June and July, particularly in the South and also in California. What about that analogy teaches us what October and November are going to be like, and what about it is flawed because things have changed? And then kind of what are those things if they have?
No, I think there could easily be a third wave. And I didn't talk about colleges and universities, but, just take what you see in colleges and universities, extend it to middle schools and high schools. That's your third wave, mm-hmm. on top of whatever's going on with, kind of indigenous transmission in the Latino communities here. But it's, I think that if we really get back into school, and there really is not universal masking all the time. I'm not just talking when they're on school grounds, but all the time when people are hanging out. Every high school is a mini Sturgis, South Dakota, as is every frat party, right? And then, you can not only get transmission there, but you also get secondary transmission. And I'm afraid that's where the next wave, if it comes, will come from.
And is your sense that it will be in the Midwest because they haven't got hit yet, and therefore maybe behaviors?
Yeah, that's just kind of a lag. That's still the same June, July, August outbreak. That's just kind of finally getting to the upper Midwest. I think when it starts snowing, which was yesterday, by the way, that it's we'll either see, and if schools remain out, I think we'll see much less sort of social interaction and less transmission.
I'm sorry, Monica, yeah, thanks. Monica, did you want to add anything?
I mean, I have to say that the outbreaks have been more in settings where haven't masked, and things like Jerusalem and frat parties get a lot of attention. But I do think that if we can increase masking, we will see less of that, mm-hmm. that problem.
Maybe last question for you guys is early on there was a meme that that COVID is like the flu. That, of course, became sort of a political thing. But at some point, the mortality rate could fall enough so that it is actually like the flu. First of all, are we there yet? And second of all, is there a risk that people will let their guard down as the mortality rate falls? It does, in some ways it's incredibly good news. And on the other hand, there's this potential that people will say, okay, good, it's not so bad if I get it, I'm going to probably do fine. So maybe Monica, why don't you take that first?
I think it is true that the case fatality rate is falling. It's still higher than influenza, except in 1918 and 1950s. And I think that it could fall, but that isn't, and it is falling, but it is in the setting of doing something really bizarre, which is universal level masking, which we really haven't done ever on influenzas. We could probably stop influenza every year if we did that. And it is still with behavior change. So I think still keeping some of these behavior changes, of course, like large crowds and masking, I think it may make some people let their guard down, but it was deadly and it was a terrible virus, and I would not do that at the moment. And I don't think any public health person would say it's time to go back to normal.
And so the best evidence would be, if you believe masking is an important part of it, that if we let our guard down and stop wearing masks, we would flip right back up, maybe not to where we were because of the changes in demographics and the therapies, but up quite a bit from where we are now.
I think it is really contributing to why we're doing better, is the masking.
Okay. George, anything you want to add about that?
Yeah, let's recall 1996 and treatment optimism following the Vancouver AIDS conference, when there was a huge outbreaks of HIV among throughout Western Europe and the United States, among populations that had been highly educated about prevention. And it really was this whole kind of opening the door that, we could make this go away, sort of. And it led to treatment optimism and increased transmission. So I think there's a clear analogy there.
Yeah, great. All right, well, thank you both. Really appreciate it. Let's bring on Aashish and keep up the great work. And we're learning a ton from what you're both doing. Thank you. Aashish, I won't reintroduce you, but Aashish Manglik is going to talk to us about this innovative new approach to combating the coronavirus. So thanks so much.
Great, thanks for having me. So what I'd like to talk to you about today is some research that we've done in the lab that's really quite different from what our normal research program is. And this is work that really reflects the amazing basic science, infrastructure and support and community we have at UCSF. So the premise of what we've developed is an aerosolized nanobody. I'll explain what a nanobody is in a little bit, for SARS-CoV-2 passive immunization. Next slide, please. Just lost the slide, at least on my screen. Great. So the fundamental thing to remember about this virus and all beta coronaviruses, in fact, many viruses, is that for an infection to happen, there needs to be at least a biochemical interaction that enables the virus to interact with its cell surface receptor. So in this case, for SARS viruses, and specifically for SARS-CoV-2, there's a critical interaction between the spike protein that's on the surface of the virus and the ACE2 receptor, or the angiotensin converting enzyme 2 receptor, initially thought to be predominantly in the airways, but now known to be really distributed all throughout the body. But it's really this one-on-one interaction that's absolutely critical for the virus to get into cells of the human body in the first place. With approaches in modern protein biophysics and structural biology, many over the past 17 years since the emergence of the first SARS virus have mapped this binary interaction between the spike protein and ACE2. And that's what's shown on the right there in those little surface diagrams. What's important to remember here is that blocking this binary interaction is a very potent way to neutralize viral entry. And a number of the vaccine strategies that are currently in development, both of the mRNA-based vaccines that Dr. Rutherford just talked about, are aiming to block this interaction. And in fact, even for the AstraZeneca vaccine, this is probably going to end up being one of the primary modes in which that vaccine is effective. So that's one way of trying to target the virus, is this vaccine, which is something that we all want. But the alternative is to provide molecules or approaches that would inhibit this interaction in so-called passive immunity. Next slide, please. So let me kind of get into passive immunity for SARS-CoV-2. There's two major strategies. The first is convalescent plasma, and this is a pretty old idea. This goes back almost 100 years and essentially could be used in any new pandemic. The idea is simple. You basically take blood from patients who have recovered from, in this case, COVID-19, but it could be from any other new infection, and then harvest plasma in this case, and then administer that to a patient that's sick with the virus. Now, the FDA provided an emergency use authorization in a very politicized kind of decision at the end of August for this. And subsequently, an NIH panel independently evaluated the data that this EUA was based on and found that there's insufficient data to recommend use. So I know that this will probably get covered a lot more extensively in future talks, but that's kind of where the field stands right now. And broadly, while this is a great, potentially a great idea, there's non-standardized protocols for which donors are good and how to administer this. So what we really need is more study and prospective randomized trials. Next slide, please. The other approach to passive immunity is the use of monoclonal antibodies, and the idea here is patient that's recovered from the virus, in some instances might have made a really amazingly potent antibody at neutralizing the virus. And if one could identify such a neutralizing antibody from a patient or from some other method, manufacture that at scale. So now it's not just a polyclonal, response that a patient has, but really a single agent that could be administered to a sick patient that could have some efficacy. I apologize for the kind of issues with the slides here, but I'm going to keep going forward. So there's a couple of candidates in clinical trials for this kind of approach, but fundamentally all of these approaches require intravenous dosing for either for early treatment or for prophylaxis. One of the big challenges here is that the doses required for prophylactic uses are really quite large because only a small fraction of the administered antibody actually ends up in the pulmonary epithelia. And this actually goes back to a pretty nice conversation that Bob had with Don Ganem, a couple of months ago when he was on, describing one of the challenges that he thought, would likely, be problematic for one of these monoclonal antibody approaches. The final big challenge for monoclonal antibodies is that they're relatively expensive to produce. Next slide, please. So relatively early in the pandemic, my lab began studying something completely different. Working with Peter Walter's lab here at UCSF, decided to consider an alternative approach to passive immunization. And the premise is as such. So let's say you have a patient with COVID-19, and instead of administering a molecule through the blood to prevent infections, what if we could deliver that molecule directly to the airways, either via an aerosol, through a nebulizer, or through an intranasal spray? So if one could achieve this, the advantages would be severalfold. First is that an approach like this would enable self-administration. So potentially people who are either have just learned that they're positive with the virus or household contacts could self-administer an approach like this. And on top of that, this would be direct delivery to the site of early infection. So it would get around these issues of dosing in the right compartment. But really the fundamental challenges to achieving this, that most biologics like antibodies or monoclonal antibodies are really not stable enough to meet these kinds of demands. And on top of that, the pharmacokinetics of how one would deliver this and how often that would have to be done is relatively poorly worked out. Next slide, please. So here's where some of the technology that my lab has been developing comes into play. And that has to do with these really interesting molecules called nanobodies. So on the left of this slide is a structure or a three-dimensional picture of what conventional antibodies floating in your blood or my blood look like. As you can see, they're relatively complex. Proteins are made of a heavy and a light chain. And these antibodies, obviously can be raised against essentially any kind of pathogen or any kind of antigen that you throw at them. It turns out that llamas, alpacas, and other camelids make so-called nanobodies. These are little antibody fragments that are about 1/10 the size of a conventional antibody. What's really unique about them is that they're really small, single-chain proteins, so far less complex than a conventional antibody. And they're ultra stable, which may enable really new approaches for drug delivery. But overall, they're relatively similar to human antibody heavy chains, and thereby they're really not that immunogenic. And finally, perhaps what's most important for prophylactic use is that they're relatively easy and cheap to produce. Next slide, please. So in order to discover nanobodies rapidly, one of the approaches that my lab has designed is a completely test tube way of doing this. So what we do is we take inspiration from this cool looking llama on the left. And in the lab, we create a library of synthetic nanobody sequences. And in our case, our library is about 2 billion individual nanobodies. And then we take collections of Baker's yeast and we engineer them such that each individual yeast cell displays a unique nanobody on its surface. So each one of these colors would be a unique nanobody, and we'd have a billion or so unique nanobodies in this library. And then we can go fishing from this library to identify nanobodies that bind to whatever target we want to throw at it. In this case, we took the spike protein from SARS-CoV-2 and then tried to identify nanobodies on the bottom right that bind specifically to that spike protein. So with that and a couple of other processes, we isolated 21 nanobodies. We then selected for the most stable clones because, again, we really hope to find nanobodies that we could aerosolize and deliver directly to the airways. Then we did a number of engineering steps, which I'll briefly get into, to improve the affinity of that binder to really to exceptional levels. So these molecules now bind in the femtomolar potency range. And then finally, we fully humanized the molecule to decrease any probability of an immunogenic response. Next slide, please. So I'm going to get into a little bit of the nitty gritty of how these things work, because, with a really great collaboration between my lab and the UCSF Structural Biology Consortium led by the physician scientist Oren Rosenberg and a QBI fellow, Klim Verba, we have a really atomic level description of how our reagents work. So what's being shown on the left here is the spike protein. And one of the things that's really unique about the spike protein is that it changes its shape in order to engage the ACE2 receptor. So this little area called the receptor binding domain has to essentially flip up in order to bind ACE2. Next slide, please. So again, with the help of this QCRG consortium, we've been able to map now at very high resolution how one of these AeroNabs or nanobodies binds, and that's shown in red here. So what you're looking at is the spike protein kind of from the side, and the viral membrane would be on the bottom. And what you can hopefully see is that one of these AeroNabs sits exactly where the ACE2 receptor would bind and just sterically competes and prevents the ACE2 receptor from binding. But what's shown on the bottom right there is the really unique mechanism of action of one of these AeroNabs, which is that it binds one of these receptor binding domains and simultaneously with another arm holds a neighboring receptor binding domain down. Next slide, please. So what that leads to is a really unique mechanism of action. Not only do we prevent that ACE2 receptor from binding, but we also basically lock the spike in this conformation that's completely incapable of interacting with ACE2 in the first place. So with that in mind, we took two further optimization strategies. We first, with kind of classic methods in protein engineering, improved the affinity of each one of these little red molecules about 500-fold. And then if you can kind of see this middle panel here, looking top down now, perhaps what you can observe is that these AeroNabs bind in a very symmetric manner to the trimeric spike. So we did a very simple trick. We basically made a trimeric molecule where we take one unit of these AeroNabs, link it to the neighboring unit, and then link it to the neighboring unit. So we have three little beads on a string. And when we do that, what we end up getting is a molecule that neutralizes the virus with picomolar potency. And once it binds to the virus, it basically never lets go. So, in the experiments that we can do in the lab, we can bound it and say it takes at least longer than 8 days for it to fall off. Next slide, please. Finally, one of the key things that we wanted to make sure is that this molecule is actually quite stable. And in a series of experiments we were able to show that the molecule is really quite heat stable with a melting temperature in the 60-degree range, and that it could survive aerosolization and it could survive lyophilization, which is basically drying it down to a powder. So all of these things now, really suggest to us that we have a really exciting molecule that may enable this premise of delivering something directly to the airways in a patient-friendly format that provides passive immunity in a very different manner than a lot of the approaches that are being trialed right now. But as with many kind of academic discovery projects, next slide, please. We're really at the stage where we're trying to cross the valley of death. So this is a nice picture that my wife and I took on the way back from Las Vegas to back to San Francisco, and this is Death Valley for those of you who recognize. And we think we're kind of on the right side of this valley, and we hope to not happen is basically caught on the bottom of these salt flats and make it over to the other side. And that's where we are right now. So with that, next slide, please. I'll thank some of the key people that have been involved with this project. Really, this work has been an amazing collaboration with Peter Walter's lab here at UCSF, led by graduate student Michael Schuff, along with a whole cadre of really amazing trainees, collaborators at a variety of places, including the Institute Pasteur, to help us do a lot of the live virus work, especially early on when a lot of the BSL-3 facilities hadn't been set up. And on the right is this QBI coronavirus consortium led by, again, Oren Rosenberg and Clem Verba, and an amazing set of 50 or so trainees that have enabled us to very rapidly understand at atomic detail how our molecules work. Thank you, and hopefully we have a little bit of time for questions.
Great, thank you. Wow, that's extraordinary. So where are you at in this sort of proof cascade? You know you can make it. You know you can make a stable version of it. You know that you can blow it into someone's nose and that it will bind the receptor. Do you know that it would then prevent the actual virus from taking hold? And do you know yet maybe in animal models that it would prevent disease?
Yeah, great question. So from the very in vitro work, which is again using the actual authentic SARS viruses, again work with Institute Pasteur, we know that it very potently inhibits the virus. It's among the most potent inhibitors of viral entry that's been described in the literature. So really now the question is, does it work in an animal model? And even if it doesn't work in an animal model, really, I think the big question at this point is can it be dosed in a way that is effective? One for early infections, where basically right now we have very little else to offer, and then ideally, really, the pipe dream is for prophylactic use. But that is a much more complicated scenario because you're now really looking at even small levels of safety issues. You have to balance that against the gain thereof. So we think that the really disproportionate advantage for an approach like this would be a very early therapeutic. Someone who's just learned that they're ill. From the perspective of where we are for testing, it's still pretty early days.
Right. Describe how that would work. I mean, in my lay person's thinking about this, it would be like, okay, my receptors are coded and I'm at a party and I get a dose and it just has no place to gain purchase. But you're describing a world in which it's already in there, maybe a relatively small number of copies. Am I coding the rest of my receptors so that this virus, as it's trying to replicate itself, has no place to go?
So just to be clear, the reagent is, the molecule is incredibly specific for the spike protein. So it doesn't see the ACE receptors at all.
Okay.
So the idea would be that you basically, dose once a day. And it turns out there's actually some precedence for inhaled nanobodies for respiratory syncytial virus in infants. And what that group learned as part of their drug development was that the pharmacokinetics of a very similar, that similar architecture molecule is that it's cleared about with a half-life of about 20 hours. So we're estimating that, at least from the aerosolized perspective, where it's delivered deep into the airways, this would be something that would be, that someone would self-administer once a day, and that would provide coverage for let's say for that following day.
But just take me through kind of what it is that it's doing in somebody who, if you're sort of going through two scenarios. One is prophylactic. I am going to have a high-risk exposure. There's an outbreak in the nursing home, let's say, but I'm not infected yet. So what would it be doing in that circumstance? But then the one it sounds like you're describing is I am already infected, and somehow putting this aerosol in me is going to prevent, to lead to a less severe infection or maybe an asymptomatic infection. In that case, what does it actually do? How is that actually working?
Yeah, so for a viral life cycle to happen, the virus has to infect an individual cell, make copies, and then those copies get released, and those released copies then have to go to a neighboring cell, and right. So with a molecule like this around, you basically prevent those additional infections of neighboring cells, and this is the point that Don really made when he was on here, in this forum, which was that the Ebola approaches to passive immunity worked so well because that was really a blood-borne virus. So, targeting the blood compartment with passive immunity strategies was likely to work because the viral life cycle really was through the blood. But in early cases of infection, especially with this virus, SARS-CoV-2, it's likely that a lot of that early replication is really happening within the pulmonary epithelia or perhaps in the nasal passageway. So targeting that at high doses is probably important, and that's where some of the challenges with targeting early infections with passive immunization strategies may have challenges.
And you took us through, let's say, monoclonal antibodies. Is there a version of monoclonal antibodies that can be used intranasally or through the respiratory tract, or it's fundamentally, if you're using antibodies, they have to be in the bloodstream?
So there are some antibodies that are stable enough. There's no approved monoclonal antibody. I would say there's actually no approved nanobody that's approved for inhaled use. So this is still charting relatively new ground. But in general, just the effector portions, the FC portions of antibodies makes them relatively less stable, and aerosolizing them as a result is far less successful. So that's really the key differentiator, at least from a protein perspective.
Got it. And I got a little confused about the timing. I thought you just said that you might have to dose it every day, but I thought you said earlier that it lasts a week or so.
Yeah, so that's the biochemical. Once it binds to the target, how long does that little biochemical interaction last? And that, basically once it binds, it never falls off. That's just, if you had an isolated system, but the body clears the molecule, right? So the inhaled molecule will probably get cleared from the pulmonary epithelium on the order of about a day, which is why you need reapplication.
So take me through, I'm sure you have a pitch deck and you're talking to people about how this would work. Give me the kind of use case. Let's say you get this thing developed and it hits all of its benchmarks. Who would be using it? When would they be using it? How do you envision this actually working in real life?
I think especially from the perspective of patients for who we have very little else to offer, I think patients who are very early in the course of infection would be, again, great potential candidates to benefit from something like this. And then early on, doing broad scale prophylaxis trials is probably challenging, but post-exposure prophylaxis may be something that's far more tractable. So people who are around that initial case that have been contact traced and are now self-quarantining instead of just staying home and kind of waiting until they turn positive or start to get quite sick, those people could be great candidates for an approach like this. And then on top of that, high risk things, if you're about to take a flight, which is kind of moderate risk now, but depending on, or if you're a healthcare worker, or if you're in a certain part of, if you're meatpacking plant work or something along those lines, those could be, again, good examples of individuals who might be good candidates for pre-exposure prophylaxis, essentially. So, using a lot of the language that has been developed in the HIV space for some of those molecules.
One of our watchers asked what potential adverse effects might be expected with receptor blockade. So have you seen anything? And then and also theoretically with this technique, what would you worry about?
Yeah, just to be clear again, so it's really targeting the spike protein on the virus, and it's not, it doesn't touch the ACE receptor at all. So from the perspective of safety, because the molecule is relatively specific, or really quite specific for the virus, and doesn't modulate host physiology, at least to our knowledge, we don't think there's a clear safety issue going in. Really, any potential safety issues may come from off-target, binding of a molecule like this. But one of the key things here is that, unlike regular antibodies that really do much more than bind, these molecules don't have any of those functionality. So they don't, for example, opsonize things. They don't, have recruit macrophages or things like that. So they're really kind of stripped down binders, and as a result, we think they'll be relatively safe. But again, for all these kinds of things, there's always a possibility of something completely unforeseen, and that's why one has to do the appropriate safety studies.
Yeah, as you're going through the science of this and the computer modeling and the work you've done in the lab and the level of collaboration, could you have done this 5 years ago, or is this all dependent on sort of new things that we've learned in the last several years? And I'm also just struck by the speed that you got this done in, I guess, 4 or 5, 6 months.
Yeah, the speed really speaks to the trainees and their enthusiasm and their desire to meet the moment. The methodology for structural biology was really been revolutionized in part because of some advances made here at UCSF. to be able to enable us to get these kinds of high resolution pictures very rapidly. And that's something that I think 5 years ago maybe was possible, but definitely not at the rate in order to practically enable us to go very fast and use that information to develop molecules faster.
Yeah. So now you're out, I think, trying to find a commercial partner to kind of make this happen and then scale it. What are you finding in these conversations? And I guess I wonder, are you hearing that, well, it's going to take 3 to 6 to whatever months to gear up, and by that time we'll have a vaccine and it will be unnecessary? Is that coming up?
Yeah, I think it's, we all, including us, want that durable vaccine that's deployable and available. And the people on the other end that, have to make an investment now to move a program forward, move this program forward, are really weighing that. So there's still, groups that understand, and I think a number of groups will understand that getting really that broadly deployable vaccine is still going to take time. And so there's still an opportunity, and as a result, there's a couple of groups that we're still in deep discussions with on what it would take to move it forward, and they remain pretty interested.
Good. Well, it just does strike me that if you get a 50% efficacious vaccine with a 50% uptake rate, that even if it gets approved in the next 3, 4, 5 months, is not going to be widely distributed for another 6 months after that. We're talking about 12 to 18 months before, so you really have had the kind of impact that might make this less relevant. So it sounds like you do have a significant window that I hope you're successful in doing it. Great, thank you so much for the work. It's really exciting, and thank you for sharing it with us, and good luck with taking it to the next stage.
Thanks for having me.
So with that, we will sign off. Let me thank my colleagues who helped put this together. You see their names on the screen. We will be back next week. As I said, our focus next week will be on vaccines, and we'll spend the entire session on vaccines. Peter Hotez is really one of the world's experts, and you can't turn on CNN or MSNBC these days without seeing him discuss where we are on vaccines, both the science, the policy, the politics. It's a lot. The week after, I think we're going to spend the entire time talking about the San Francisco experience with some of the leaders from the city as well as from UCSF. And then we will toggle to every other week COVID, every other week, the rest of healthcare and medicine. But for now, we will sign off and see you again next week. Again, this will be posted on YouTube tonight, and I will tweet about it, including the address. Thanks so much for joining us.